Hello, my name is Allison Conti, and my presentation is on liver cirrhosis. In this presentation, I'm going to discuss the chief complaint, differential diagnoses, pathophysiology and clinical manifestations, laboratory and diagnostic studies, pharmacological and non-pharmacological treatments, cultural and sociocultural considerations, prognosis and expected health outcomes, as well as teaching and anticipatory guidance. Liver cirrhosis is a chronic disease developing from fibrosis and inflammation of liver tissues, which most commonly is caused by alcohol use disorder, viral hepatitis, or non-alcoholic fatty liver disease. Cirrhosis progresses from a compensated stage, which is asymptomatic, to a decompensated stage, which is symptomatic. And in the beginning stages, fibrosis can be reversed, but at a certain point, they can no longer be reversed once symptoms have gotten too severe. After an extended period of liver inflammation, healthy liver parenchyma are replaced with fibrotic tissue and regenerative nodules, contributing to portal hypertension, which we'll later discuss in this presentation. This condition can cause different lobes of the liver to be variously affected, leading to alternate changes in severity of scarring and impairment of function within the different lobes. Chief complaint. So ascites is a major chief complaint for patients with liver cirrhosis. This is when distension occurs and pathologic fluid accumulates in the abdominal region as cirrhosis progresses and as portal hypertension develops. Abdominal pain is a common symptom many liver cirrhosis patients experience, and it's typically in the upper right quadrant because this is where the liver is located. Nausea is another symptom patients experience with liver cirrhosis, and this is due to the delay in gastric emptying. When this occurs, patients often lose their appetite and have an increase in weight loss as well. Jaundice is another symptom patients experience. This is the yellowing discoloration of the skin, typically in the face, mucosal membranes, and conjunctiva. This is a result of a bilirubin buildup. Fatigue is another symptom patients may experience, and this is due to the liver playing a pivotal role in regulating the production, release, and storage of energy sources. Encephalopathy is another symptom patients may experience in regards to liver cirrhosis, and this is a change in mentation due to the accumulation of gut-derived neurotoxins. They build up in the body as a result of poor vascular shunting and decreased liver mass. Differential diagnoses. Constructive pericarditis is the main consideration in differential diagnosis for liver cirrhosis, and this is because they both lead to portal hypertension. In the liver, portal hypertension is when the resistance of portal blood flow increases in the liver, and in constructive pericarditis, this occurs posthepatically. Cor pulmonale is another differential diagnosis for cirrhosis, or liver cirrhosis, and this is when pulmonary heart disease causes the right side of the heart to fail. And the presenting symptoms is liver swelling, which is why it can be easily mistaken for liver cirrhosis. This is why different tests such as blood antibody tests, chest x-ray, echocardiogram, and chest CTs are used to decipher between the two. Dilated cardiomyopathy is also similar to liver cirrhosis because it can be caused by an increase in alcohol consumption and appears with symptoms such as hepatomegaly. A jugular venous pressure can assist in differentiating between dilated cardiomyopathy and liver cirrhosis. Inferior vena cava thrombosis presents with abdominal tenderness and pain and protruding abdominal veins, which are similar symptoms to liver cirrhosis. This can be diagnosed through a CT scan of the abdomen. Nodular regenerative hyperplasia occurs, and normal hepatic parenchyma transform into small regenerative nodules that disperse in the liver. This helps contribute to portal hypertension. Its presenting symptoms are similar to liver cirrhosis, such as jaundice, abdominal distension, and ascites. Differentiating between these two diseases is done through a liver biopsy. Pathophysiological factors like hepatic fibrosis. This occurs when the hepatic statolite cells transform into fibrogenic myofibroblasts. This increases the expression of inflammatory receptors such as chemokine receptors and ICAM1, as well as molecules that attract immune response. If the HSC cells continue to transform, this leads to accumulation of extracellular matrix over time and results in hepatic fibrosis and liver stiffness, which affects the liver function. These HSC cells also play a role in portal hypertension. The accumulation of the extracellular matrix causes this fibrosis and restricts blood flow. So during portal hypertension, nitric oxide levels also decrease while the vasoconstrictors increase, and this causes the blood vessels to narrow, and both of these factors contribute to portal hypertension. Cardiomyopathy is another pathophysiological finding, and this happens when the heart has an increased exposure to these vasoactive factors such as angiotensin II and norepinephrine. This increases the strain on the heart, which increases the development or worsening of cardiomyopathy. Inflammation is another pathophysiological factor. Regulatory mechanisms that assist in monitoring the innate immune response become ineffective, and this leads to elevation of post-inflammatory and anti-inflammatory cytokines, which encourages the advancement of the acute on chronic liver failure and promotes the development of decompensated cirrhosis. Clinical manifestations. Esophageal varices are very common, and they present with melena or an upper GI bleed. This is a very common and life-threatening complication of cirrhosis and is usually caused by a raise in portal pressure. Ascites is another common clinical manifestation, and this is when the peritoneal cavity has fluid accumulation and causes abdominal distension. This can be influenced by 3 different factors: an increase in hydrostatic pressure causing a raise in portal pressure, a decrease in albumin as a result of reduced oncotic pressure, and a release in nitric oxide causes splenic vasodilation. Hepatic encephalopathy is another clinical manifestation, and this is the altered mentation. It causes altered mentation. This occurs when there's a buildup of ammonia. It's the liver's role to detoxify harmful substances, but when cirrhosis occurs, the liver's ability to eliminate ammonia is reduced. Jaundice is another clinical manifestation, and this is due to the buildup of bilirubin. In patients with cirrhosis, the damaged liver parenchyma lose their ability to process the bilirubin efficiently and effectively, leading to a buildup of bilirubin in the tissues. Hepatorenal syndrome is affected by the restricted blood flow that occurs with liver cirrhosis. When the renal vessels are constricted, there's a reduction of blood flow to the kidneys, which reduces renal function. Ecchymosis, which is bruising, this can be caused in cirrhosis patients due to the liver's reduced production of clotting factors. By testing PT, INR, and PTT, this can help monitor patients for their risk of bleeding and impaired clotting. Laboratory diagnostic studies used for identification and diagnosis of liver cirrhosis. Abdominal ultrasounds are used to determine the size and echogenicity, nodularity of the liver, and measure of portal vein diameter. As the portal vein diameter increases, it worsens portal hypertension. CT of the abdomen is often used to detect for liver lesions and biliary obstructions. Biliary obstructions can cause an increase in bilirubin, which results in jaundice. If this test is done sooner rather than later, a biliary obstruction could be identified before visible symptoms are present, and visible symptoms become present when the bilirubin gets to 2 milligrams per deciliter or greater. Transient elastography, this has become more popular test to be done because it assesses the liver as a whole. It assesses the liver's stiffness, and it's a non-invasive treatment. During the TE test, it initiates shear wave elastography, which measures the velocity and low frequency electric shear waves that are spread throughout the liver. And the faster that these electric waves move, the stiffer the liver is. This is not a good test for patients who have increased abdominal fat because it will affect the way that these electric waves move. Wedge hepatic venous pressure is also used to help diagnose liver cirrhosis, and it accurately estimates portal pressure, but specifically in patients with alcohol-induced cirrhosis or viral hepatitis-induced cirrhosis. When patients have cirrhosis from other origins, this is not the test of choice. Upper endoscopies are also used to help manage symptoms of cirrhosis and diagnosing cirrhosis by assessing for esophageal varices. Liver biopsies remain the standard test to confirm diagnosis of liver cirrhosis. This is typically done after some of these other diagnostic tests have been completed. If there are some conflicting results within those, they'll do a liver biopsy to confirm diagnosis. Management and treatment. Alcohol abstinence is the primary educational promotion for patients with liver cirrhosis. It's important to make sure that they are abstaining from alcohol and have access to resources such as support groups or rehabilitation facilities to prevent them from consuming alcohol. Different medications can also be given to reduce the risk of complications associated with liver cirrhosis or reduce symptoms. Spironolactone with loop diuretic is used for symptom management with ascites. Oral antibiotic is used prophylactically against spontaneous bacterial peritonitis. Vasoconstrictors like teleropressant are used to help reduce portal hypertension and promote blood flow to the kidneys to encourage kidney perfusion. Albumin infusions are also used to increase patients' protein, which promotes oncotic pressure maintenance, and it also encourages blood flow to the kidneys to promote kidney perfusion. Lactulose and rifaximin are both used in patients with high ammonia levels. The lactulose ammonia converts to ammonia ions, which decreases the ammonia's absorption in the GI tract, and the rifaximin decreases ammonia production by gut flora. Propranolol is also used prophylactically to help prevent esophageal varices. It's also important to mention to these patients about a proper well-balanced diet while reducing their sodium intake and increasing their protein intake to more specifically help with ascites management and prevention. Vaccines like hepatitis A and B vaccines and flu vaccines are important to promote in patients with liver cirrhosis. The TIPS procedure, transjugular intrahepatic post-systemic shunt, this has actually been used in earlier stages of cirrhosis development in patients who are not compliant with other forms of therapy. They've been using this a little bit earlier in the diagnosis, and it's had good results in high survival rates. It's also used as a secondary form of therapy for patients who have recurrent variceal hemorrhage, or to use to help with treatment of ascites. But at the end of the day, with cirrhosis, the only real treatment for it is a liver transplant, which can be hard to obtain. The socioeconomic status of people, low in economic status and lower levels of education are associated with higher risks of mortality with people with chronic diseases like liver cirrhosis. Language barriers and difficulty with communication can put patients at an increased risk for not getting the proper care they need for chronic diseases like cirrhosis, or not being aware of different interventions they should be implementing into their life if there is a language barrier. That's why it's important to use a translator when communicating with patients who do not speak your same language. Accessibility to healthcare is a major issue because adults with lack of insurance coverage or accessibility to affordable healthcare tend not to go to their primary care every year, where different forms of chronic diseases like cirrhosis could be detected at an earlier stage. Additionally, lower income minority communities tend to be at a disadvantage due to the denser alcohol outlet densities and proximity to alcohol outlets in these areas, in combination with their disinvestments in the areas and limited access to health care. This results in them facing higher disease burdens. So the prognosis and expected health outcomes of liver cirrhosis would be using screening tools like the Child Prog score. This assesses liver function using 5 factors: ascites, bilirubin, albumin, prothrombin time, and encephalopathy. It's graded from class A, which is compensated, to class C, which is decompensated. The MELD score is also used to prioritize patients for liver transplants. So this test is calculated by using 3 different lab values: the bilirubin, serum creatinine, and the INR. So the higher the score, the higher need for a transplant, liver transplant. The teaching and guidance: alcohol abstinence is the most important, and promoting regular screening of hepatitis B and C, while also promoting vaccinations like hepatitis A and B and the flu. Avoiding iron supplements and hepatotoxic drugs such as aspirin or acetaminophen are also important when educating your patient who has liver cirrhosis. Continuing to keep medical appointments to monitor CBC, CMP, and prothrombin time. Offering referrals to dietitians, social workers, and community nurses to help prevent complications in the future, as well as advising them to avoid exposure to brackish saltwater and consumption of raw seafood, because this puts them at an increased risk of contracting Vibrio vulnificus, which is a bacterial infection, and also avoiding unpasteurized dairy. This puts them at an increased risk of contracting Listeria infections. In conclusion, we have discussed an overview of liver cirrhosis, the pathophysiology, clinical manifestations, diagnostic studies, management and treatment, cultural and socioeconomic considerations, prognosis and expected health outcomes, teaching guidance associated with this disease. These are my resources.